I have no disclosures. Just looking at the talks that are coming up, so the PFO closure story has kind of had some twists and some bends, and so we'll go through the data, and then Mario will talk about the devices available to us, and then Dr. Carroll will go through what's coming in the future. So just a little bit of background. PFO frequently persists into adulthood. About 20 to 30% of patients in autopsy studies and TE studies show that they do have PFOs, and most of these are asymptomatic. The cryptogenic stroke is the most important manifestation of this. About 40% of ischemic strokes in patients less than 55 years of age have been determined to be cryptogenic. And then in the PFO atrial septal aneurysm study, about 37% of these patients had a PFO, and 8% had a PFO and an atrial septal aneurysm. So why is this important? It is a pathway for left to right shunting. About 57% of patients with a PFO have shunting at rest, and that increases to 92% with any straining or coughing. Migraines, vascular headaches, decompression sickness, and air embolism, patypnea, and orthodeoxy syndrome have all been thought to be related to PFOs, although maybe not necessarily definitive in each of those yet. So what are our therapies currently? So medical therapy is an option. There's percutaneous closure, and then rarely done is surgical closure, which is usually done in association with another open heart surgery. It has been a little bit controversial. What role does the PFO exactly play in cerebral ischemia? We don't know for sure. At least initially we didn't. The first trials did fail to show significant reduction in stroke risk with PFO closure. We'll go through these. There were a lot of problems with these trials. So number one, the closure trial was a randomized controlled trial, 900 patients with stroke and CVA at 6 months. This was using the Starflex device, which is no longer on the market now, with 6 months of dual antiplatelet therapy versus anticoagulation, aspirin, or both. There was 2-year follow-up. The hazard ratio was 0.78, and it was not significant with a p-value of 0.37, as you can see here. The next one was the RESPECT trial, which Dr. Carroll can talk a lot about. It's a randomized trial with 980 patients with stroke or a TIA at 9 months. This used the Amplatzer device with 1 month of dual antiplatelet therapy versus warfarin or antiplatelet therapy. There was a total of 4 separate options for therapy arms in this trial. It was event-driven. Once they reached 25 events, the trial was halted. The hazard ratio here was 0.49, and it wasn't quite statistically significant with a p-value of 0.8, as you can see here. And then the PCPFO trial was also a randomized trial, 400 patients that had stroke or TIA or an extracranial thrombosis somewhere. Also used the Amplatzer device with 1 to 6 months of antiplatelet therapy versus warfarin, aspirin, or both. At 5 years of follow-up, the hazard ratio here was 0.63 and the p-value was 0.34. So there were a lot of issues that were outlined very nicely by Dominic and John in a recent paper that I'd recommend that kind of goes through in detail each of these trials as well as the latest ones. But in particular, they were underpowered with a very low event frequency. Longer follow-up was definitely needed. Some more rigorous and sensitive testing of the events due to the low event rate would help maybe choose your patients a little bit better. The actual role of the device in causing stroke after the procedure is done. And then for enrollment, looking specifically at patients that have had embolic strokes and maybe not including TIA and having some kind of verification of these events. There was a lot of non-standardization of the medical therapy arms, as you saw there. Anatomy does play a large role in the future risk, particularly in patients that have atrial septal aneurysm, and then a collaboration with neurology is critical. That really wasn't done in the initial trials. So after a lot of initial excitement, we kind of saw the data and it was like, I don't really know what's going on. But then, on September 14th, 2017, this is a great edition of AnyJam if you're interested in PFO closure. It was kind of a reawakening, and we got some data that was a little bit more exciting. So the long-term follow-up for the RESPECT trial with a median follow-up of 5.9 years, again, all the same, 980 patients with stroke within 9 months or TIA. Again, the Amplatzer device with the same 4 treatment options. For treatment exposure, there was 3141 patient years for PFO versus 2669 for the medical therapy. There was a lot of dropout for patients that did end up crossing over. Hazard ratio here was 0.55 with a p-value of 0.46, which was great. The closed trial was also presented in this article, which was a randomized controlled trial of 663 patients, stroke within 6 months. These patients specifically had a PFO with an atrial septal aneurysm or evidence of a large shunt on echo, which is important for later. Kind of interesting on this one, they were allowed to use any device they wanted with 3 months of dual antiplatelet therapy and then single antiplatelet therapy after that versus single antiplatelet therapy versus a target-specific oral anticoagulant. There's a mean of 5.3 years for follow-up here. The hazard ratio is 0.03 with a p-value of less than 0.01. It was a little bit underpowered. That was one of the criticisms, but as you can see, a very significant result here. And then the reduced trial, randomized trial with 664 patients with a stroke within 6 months. This used the Helix device with 6 months of dual antiplatelet therapy versus aspirin, dual antiplatelet therapy, or single antiplatelet therapy after that. The follow-up was about 3.2 years with a hazard ratio of 2.3 and a p-value of 0.02. One thing to note here, there was a high rate of atrial fibrillation noted after closure, and about 59% of cases of this resolved within 2 weeks. There was one stroke in a patient that had AFib post-PFO closure, so important to make sure these patients are monitored after the device is implanted. But again, as you can see, significant results there. And then not in this, in that NEJM journal, but a little bit later, the Defense PFO trial came out, which was a randomized trial with 120 patients that had a stroke within 6 months, and also, again, a high-risk PFO that was determined by either having an atrial septal aneurysm, hypermobility of the septum more than 10 millimeters, or the PFO itself was greater than 2 millimeters. They used the Amplatzer device in this trial with 6 months of dual antiplatelet therapy or target-specific anticoagulant, or just any antiplatelet therapy after that. There was a 2-year follow-up with a 12.9% event rate, and the conclusions here was that the closure of the PFO was superior to medical therapy alone if it had these high-risk features. And again, you can see a significant result there. So then looking at the guidelines, the chest physicians guidelines, the AHA and Stroke Association, as well as the neurology guidelines are all outdated. These were published before 2017. So numbers 4 and 5 here you can see. They don't support PFO closure in patients that have a TIA or PFO without evidence of a DVT, or on basically a class 2B recommendation after that. The Canadian best stroke practice recommendations have been updated, and those do give kind of a soft recommendation for PFO closure, and then we're expecting American guidelines to be updated soon. Although on Thursday, this was kind of interesting, the British Medical Journal just published a clinical practice guideline update that the editorials had some kind of weird wording. They said it's slightly recommended to close a PFO and use antiplatelet therapy in patients under 60 with a cryptogenic stroke and a PFO. So they have a nice little layout here of their conclusions. And so for patients in which anticoagulants are contraindicated, they do recommend, it's a strong recommendation for PFO closure. If device closure is possible, or if anticoagulants are also available, they have a weak suggestion for PFO closure. And if there's a reason, if for some reason there's a contraindication to closure, then there's a weak recommendation for anticoagulation. Again, back in that same paper by Dominic and John, there's a nice proposed algorithm really emphasizing that involving your neurologist and kind of taking a team approach that we've learned from our valve devices, you can really get some good results, and including the patient, obviously, in the decision is important as well. So in conclusion, percutaneous PFO closure is more effective than antiplatelet therapy alone to reduce recurrent strokes in specific patient populations, specifically patients that are less than 60 that have an embolic appearing stroke and have a PFO present. PFO closure is safe, and there's a low complication rate. The guidelines are likely to change soon, and further studies are underway. Thank you.
A quick question for Dr. Carroll. You know, all these 3 devices used a somewhat different post-implant drug regimen. What's your practice, and what do you recommend?
Typically at least several months of dual antiplatelet therapy, then transitioning to aspirin alone, and then after 6 months, an issue is, do you need to continue aspirin in all these patients to cover other potential etiologies of stroke down the line, or if a particular patient's very young, is absent of any vascular risk factors, could you in fact even stop aspirin? That's where we're at this point.